Housed in Connecticut, the Early Childhood Consultation Program, also known as ECCP, is, quote, one of the first statewide, comprehensive, data-driven early childhood mental health consultation programs in the nation. ECCP has partnerships and collaborations with many state agencies to deliver services among various funding systems. One of the ways that ECCP is offered is through the Village for Families and Children, an agency in the greater Hartford area with over 500 professional staff members, including child psychologists, clinicians, social workers, and paraeducators. What is the purpose? Well, ECCP offers an immense amount of support through consultation for children, families, and classrooms. The program provides early childhood mental health prevention and intervention services for children who are at risk for suspension or expulsion from early care and educational settings due to behavioral and mental health concerns. The program offers individual child services, classroom services, child care center services, family daycare services, consultation to community providers, mental health consultation groups, social emotional training, and a continuum of care. The objectives. ECCP seeks to provide cost-effective services that make maximum use of funds servicing children, families, and early childhood professionals. ECCP believes that all young children ages birth to 5 require predictable and responsive caregivers, safe and consistent environments, healthy relationships and attachments, basic needs are met, parental supports, and quality childcare for healthy and social-emotional development. Early childhood mental health consultants like ECCP work to, quote, even the playing field for all young children, creating partnerships among the caregivers in the child's life, facilitate screenings, referral of more intensive services, and are part of a critical component within the continuum of care necessary to meet the needs of children birth to 5. According to their website, ECCP was included in 3 separate research studies. The first one was done in 2007 by Walter Gilliam, Ph.D., at Yale University School of Medicine through 3 random control treatment studies. The first out of the 3 was conducted in 2007, which compared outcomes for children who were and were not enrolled in classrooms that received the ECCP services. From this evaluation, it was concluded that the program reduced classroom behavior challenges, demonstrating changes like decreased oppositional behaviors and hyperactivity. This was one of the first large-scale randomized control treatment evaluations for a social service program servicing young children. Then, in 2009, ECCP was selected by Georgetown University Center for Child and Human Development to participate in a multi-method study of 6 early childhood mental health consultation, or ECMHC programs, to discover the essential elements of effective early childhood mental health consultation associated with positive outcomes. Then, in 2010, Walter Gilliam finished the last 2 random control evaluations, which results were consistent with those found in 2007. These 2 were conducted on the preschool services and infant-toddler services provided by ECCP. These studies were more intensive and included blind raters who provided direct observations of the target children, as well as how the program impacted random peers. All 3 evaluations clearly demonstrated ECCP's effectiveness, but the results from the infant-toddler evaluation were the most impressive. Results showed very strong effects for the ECCP social intervention on teacher-rated externalizing behaviors, observed oppositional behaviors, blind raters, homeschool collaboration, and random peers. This evaluation was significant for ECCP to build a research base for children birth to 3. This also has implications for building public policy around the needs of children birth to 3 and solid solutions of effective programming. Lastly, in September of 2016, a random control trial of ECCP was published in the Journal of the American Academy of Child and Adolescent Psychiatry. Researchers compared the outcomes between children in classrooms that received the ECCP service and children in classrooms that did not receive the service. The results were that, in classrooms where teachers received the ECCP services, children had lower rates of hyperactivity, restlessness, externalizing behaviors, and problem behaviors when compared to children in classrooms with no ECCP support. According to the ECCP website, as a result, we can confidently draw the conclusion that ECCP services help reduce a variety of challenging behaviors children display in classrooms. In addition, ECCP has been featured countless times within publications between 2006 and 2019, both nationally and internationally. Most recently, ECCP was featured in Connecticut Mirror. Program aims to reduce the suspension of Connecticut's youngest students in July of 2019.
The Early Childhood Consultation Partnership provides early childhood mental health promotion, prevention, and intervention services to children who are at risk for suspension or expulsion from early care and education settings due to behavioral and mental health concerns. Services are made available to all children, classrooms, and centers in Connecticut. Consultation services are available on a continuum of care to include center-wide services, classroom services, or individual services to the children. The consultations, which are provided by master's level mental health professionals, are provided following a request for services. The services may last from anywhere between 6 weeks to 9 months, depending on the case. For each service, the ECCP seeks to build capacity through partnerships in order to meet the social, emotional, and/or behavioral needs of the young child. Specific consultation topics may range anywhere from aggressive behavior in children to the tone of a classroom and responsiveness of teaching staff. The ECCP leadership team are mental health professionals with expertise in early childhood mental health consultation. The program managers and assistant program managers oversee the ongoing development and the day-to-day operations of the program.
There are 3 different types of client populations that are targeted and served by the program. Individual children ages 0 to 5 years old, early childhood care classroom-wide services for both the students and the teachers in the classroom, and lastly, center-wide services to support all teachers within the child care center. Specifically, the program seeks to serve and support children from ages 0 to 5 years old. The only critical eligibility that is required is that the children being supported are ages birth to 5. The other eligibility requirement is for center-wide services. For this, centers should be located in urban areas and with populations of more than 150 children. For child services, referrals are made by parents, community providers, teachers, or directors who have concerns about a child birth to 5. Concerns can include anxiety, behavioral challenges such as biting, hitting, running away, difficulty with attention, poor social skills, or at risk of suspension or expulsion. Other things can include stressful events such as the birth of a sibling, parental separation, loss of a family member, or community stressors. For classroom services, referrals are made by the child care center's director or manager. Reasons for a referral include support for behavior management, improvising the social and emotional tone of the classroom, enhancing partnerships among teachers, parents, and administrators, and gaining practical strategies to support the social and emotional needs of the children in their care. For center-wide services, referrals are made by the center director and are accepted in May and June. Reasons for referral include additional support to their staff for social and emotional development of young children, building staff resilience and a sense of community, building supportive relationships with families, and increasing the overall social and emotional environment in their center.
The most common evaluation by an agency is outcome evaluation, which assesses the efficacy of a specific program in producing change for that client. Stakeholders at the village are interested in outcome evaluation as they want to be assured that the ECCP is benefiting their families and delivering on the goals of the program. The evaluation questions that answer the outcome evaluation are: does the ECCP significantly improve the social and emotional health of the child? Does the ECCP reduce the likelihood of suspension and/or expulsion from the care center preschool? Is the program equitable for all children and families? What components of the program do parents find the most effective? Does the program provide quality services and resources and cultivate useful tools and knowledge for children and caregivers? And should the program be continued as is, updated, or discontinued? A mixed methods design will be used for this study because quantitative methods provide concrete cause and effect data points that illustrate statistical significance, and qualitative methods deliver anecdotal data that provide insight to the client's assessment of the program. Each method corroborates the other and offsets weaknesses and limitations, providing a more comprehensive study than just one method used alone. The design will be a pre-test, post-test format using the Devereaux Early Childhood Assessment and the Ages and Stages Questionnaire, Social Emotional Second Edition, as well as scheduled interviews with randomly selected families 4 to 6 weeks following the completion of the ECCP. Teachers complete the DECA and caregivers are to complete the ASQ SE2. Both scales are widely recognized as reliable, valid tools to evaluate children in the 0 to 5 age range. The pre-test, post-test design can measure how much change occurred between intake and program completion. Follow-up interviews with families provide insight to the ECCP, effectiveness, and residual outcomes. A significant threat to the internal validity of the pre-test, post-test design is testing effects, the effect that taking a pre-test might have on the post-test scores. Maturation is another threat to internal validity and refers to the developmental changes that can occur during a study that influence the dependent variable. Interviewer bias or the influence of the interviewer on the interviewee may affect the interviewees and cause skewed responses. There are some potential ethical implications of our outcome evaluation design. They are confidentiality, as the evaluation cannot be conducted anonymously. Names and identifying information must be collected. However, this information is confidential and will not be shared. Sacrificing time and energy to participate, and the emotional consequences as a result of answering the standardized scales and participating in the interviews must be considered as an ethical implication. Children may also disclose, or the study may reveal, unhealthy family situations that result in reporting to the authorities and potential removal from the home. Stratified random sampling will be used for this study. This technique divides the target population, the village and clients enrolled in the ECCP, into meaningful homogeneous groups based on certain characteristics like SES and family demographics, and selects a random but equal sample from each group. This method allows you to study a wider range of the population without a larger sample size, allowing conclusions to be drawn about a more diverse population. The sample will consist of the clients of the village enrolled in the ECCP and contacted by their case manager via phone and invited to contribute to the evaluation study. Informed written consent will be required of the guardians, and when developmentally appropriate, explained to the child as well. A smaller, simple random sample of the stratified random sample will also be invited to participate in a post-mortem interview about the experience with the ECCP. Teachers of the families who consent to the study will also be invited to participate by completing the DECA for their student. This will also be required to sign a written informed consent of their participation. A client's data may only be included in the study if both the guardian and the teacher provide consent of the participation. The quantitative methods are non-invasive standardized scales that take very little time to complete. The DECA and the ASQ SE2 are incorporated as a part of the normal intake and out-processing that each guardian and teacher complete during the ECCP. Therefore, refusal to consent is not likely as the scales are used as part of the normal procedure. Furthermore, sample attrition is not likely as the ECCP may be the last opportunity for parents to help their child, and the incentive to complete the program is high. However, it may be harder to gather a sample for the qualitative postmortem interview with the guardians. This would require a larger investment of time from the family, and there may be greater barriers to participation. Upon intake to the ECCP, guardians will complete the ASQ SE2 for their child. This questionnaire is commonly used and highly regarded in the evaluation of social and emotional health in young children. Part of the ECCP is a 6-week parent-teacher consultation. Prior to the consultation, the children's teacher will complete the DECA. Again, this scale is widely recognized in the ECE field of evaluation for social and emotional health in young children. The child, guardians, and teachers will continue the ECC program, and upon completion of the program, both the guardians and the teachers will again complete either the ASQ SE2 or the DECA. Should a family consent to the follow-up interview, an appointment will be made for 4 to 6 weeks after the conclusion of the ECCP. Interviews will be informal, one-time meeting between case managers and guardians to assess the effectiveness and residual outcomes of the program. Interviews will be informal so that participants feel free to express themselves and guide the conversation. However, questions like, has your child's behavior improved? Is your child no longer at risk for expulsion? What did you find most beneficial? What was the most difficult about completing the program? Would you recommend the program, and do you have any suggestions on how to improve the program? These questions will be asked and collect data to help answer the evaluation questions. There are two hypotheses for this study. The null hypothesis is that there's no difference in the pre and post-test scores. The alternative hypothesis is that there is a difference in the pre and post-test scores. Each child's score for the DECA and the ASQ SE2 will be recorded for both the pre and post tests. The mean of these scores will be recorded as data point 1 pre-test and data point 2 post-test. The difference of these two data points will be recorded as the data point number 3 difference. With the data point number 3 difference, a paired t-test at the 95% confidence interval will be conducted to analyze statistical significance of the data. Interviews will then be recorded and transcribed. Data collected will be summarized into overarching themes. Those themes will then be compiled and analyzed for frequency, repetition, and outliers will be explored further.
One of the limitations or difficulties would be getting the child and guardian to come back 4 to 6 weeks after the conclusion of the ECCP. We would involve program staff in the evaluation process to work with the children's parents or guardians during the test and interview process. The staff knows how to assess the children's behaviors and can help work together with the guardians of the children to get an appropriate outcome. Ethical implications of our proposed evaluation is confidentiality. The answers will remain anonymous, unless of course there is an unhealthy or dangerous living environment for the child, in which case authorities would be notified.